This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Well, thank you, everybody. It's end of a long day, so we're going to bring up at the end of the mammoth effort that this day's discussion has brought. I think I too wanted to acknowledge Holly DeBoss's kind of lifetime of contribution, and what an honor it is for all three of us to be part of that acknowledgement and celebration. So, just wanted to thank Jaime for convening this meeting. Well, it's a distinct honor to be here with friends and colleagues that go back for more years than I can count. We have been in front of a challenge all of our lives and have found ourselves crossing each other's paths as we've moved through responding to it. And it's been a real honor to be with both of these gentlemen. I think they're well known to you. Paul Farber had a wonderful introduction earlier.
Sorry about the haiku.
The haiku reference was perfect. And Pauline Basinga is a doctor and a PhD in public health who has been here on the absence of Minister Benegwahu, who was unable to attend because of issues at home that she was called back by her president to confront. We are honored to have him here. He is deeply experienced in the medical delivery system in Rwanda, having been a professor in the School of Public Health in the medical school. He has taught most of the people that we have gone to see in the last, we were in Rwanda together a couple of weeks ago, and it was very gratifying to see all of his students come up to him and acknowledge their professor and the work he's currently doing at the Bill and Melinda Gates Foundation. He is working in the area that Chris was talking about in integration and has been a real thought leader in moving that agenda forward. What we're going to do today is try to talk informally about the remarkable trajectory that Rwanda took following the 1994 genocide and with the establishment of a new government and their ability to grab control of the resources as they kind of poured in after the absence in 1995 to the present and use those resources matched with their own, so the divergent resources should truly not create parallel systems, but become part of their system and not duplicate, so they were truly additive. I will ask each of them to just say a couple of words about their general thoughts on that, and then we can go into a little discussion, but I really wanted to try to open it up to the crowd and questions from the audience. So, Pauline.
Thank you very much. It's really an honor being here. I'm sure you all were expecting a BWW, a black wise woman. Agnes Binagwaho. But I'm not sure what you are getting, if it's a BMW or a Corolla, but I'm here. It's, as you know, Chris was describing where I work now. I work for the Bill and Melinda Gates Foundation and on our integrated delivery team. So we support several teams like the MNCH, HIV, TB, and have to travel a lot. And each time I need to travel, I have to talk to my manager at work and also my manager at home. And my wife, this trip was not planned and it was very difficult to come here. And then when I just, fortunately we were watching CNN and I said, by the way, I will be with Paul Farmer. He was talking about Ebola on CNN. I said, I'll be with Paul Farmer on the same panel. And she said, oh, this will be important. This will be, you can go. So it's, as, young people here in global health, I'm thrilled to be here to talk with these, people. I've been, seeing Zulfi here, seeing all the people we've been reading their books, etc., and they're talking about Rwanda. The system I know better would be great. So it's, I think one thing that today I've been listening to the talk this morning, and I realized that at the global level, a lot has been done in terms of like bringing, and since the World Health Report in 1993, the author here, since health has been really brought into the global agenda as a priority, many countries in Africa. And then after that, we had global fund being created, Gavi being created, the PEPFAR was there. I think global health has been created. You can see, because most of the American universities, School of Public Health has created a specific department of global health, which does not exist in Africa. We'll get to that later. But now the big issue Chris was talking about it is really the last mile delivery. So what is really happening with the new product, innovative product that we've created, all the intervention that we know, Zulfi was showing those interventions here, very simple intervention that can really transform the life of people. But the big issue is really how do you make those interventions happen at the community level, at the health post level, at the health center level. And what just happened in Rwanda in the past 20 years is just the system was set to make things done. So I think the lesson that we really need to learn is how does Rwanda did that? So I was listening to Stefano this morning, one of the great mentors and someone I really respect deeply. I was thinking about what I'm going to say here, that how does Rwanda did it happen? I think it's kind of, if you look at the triangle, like if I put all the global health donors and academia and all the thinking up here in the triangle, and then down in the other part of the triangle, you have everything that are implementing partners. Because if you go to Tanzania today, you go to Kenya, you'll see that the people who have really something to say are people who have money directly from the US government or from any other donors who can implement programs. JAPAIGO, FHI, PSI, ICAP, I can name a lot. And then in the other, you have the government. You have, the guy who is in charge of HIV or maternal child health, etc. And that guy does not have the capacity to control the delivery which is happening in the other side, right? Because, not well paid, not well equipped, he doesn't know well the data, but he needs to sign and to accept that, the 30 million, 40 million, 50 million implementation, goodwill, good work happening over here, but not a lot of connection between the two, right? And what Rwanda did is really to match the two bottom line. Try to really put a system where the country will have a plan, the country will have a good understanding of, we need to put in place policies, plan, and structures so that any global health initiative that will happen in country, it will be happening in a very coordinated way. Then we'll take advantage of that and we'll make things happen. So that I was working in Rwanda for 13 years in the School of Public Health. We were literally sitting in the Ministry of Health when there will be, there was, I think, 12 rounds of the Global Fund applications that many countries missed the round of the Global Fund application. I remember very well the first one was called VCT Integrate, 2002. And it was instrumental for the government of Rwanda to get that grant. So if you missed something to not be able to get the Global Fund money into the country, you were in trouble because they say you are failing the Rwandan people, right? So, but think about the countries that you've been supporting and how many countries missed a Global Fund application just because, not well equipped to write a good proposal or to have enough data to take advantage of those funding, etc. So I think that capacity to really create a very strong government coordination capacity and also to be able to coordinate partners and make it happen within government structures, I think that has made a huge, huge difference. So that it's only like in Rwanda, Ethiopia, or Malawi where you will find from the lower level, a national community health worker program. So you don't have a community health worker program for JAPAIGO or for PSI, etc. They set the program and then they tell all the donors, if you have money to train community health worker, how can we combine all those training money, supervision money, and support health centers and district hospitals to make it happen, etc. So this is one thing I think which was really instrumental. And the second, I'll stop there and then hear from Paul as well, who has been doing an amazing job in Rwanda since 2005, many, many years, is that the capacity to really empower local people. So if I'm here is because I had the opportunity to be trained using AID money by Tulane University, going to the US and coming back and be able to build the School of Public Health and be able really to support the government in the implementation. Not only doing efficacy trial that Steph was mentioning, but really embedding those trials within the implementation. I think in academia, because we are very far from the implementation, I think you guys have been doing a lot of efficacy trial to publish in a very good journal, and you are missing the point on the daily basis implementation that is happening in countries, right? And people who are doing the implementation are people who are doing classic M&Es that are not published. They are, they are dealing with their program officers in Washington, because the program officer need to report back to the Congress about how many people have been put on treatment, right? And then that is just been very vertical, and we didn't really take advantage to do a very good job of understanding implementation and scaling up programs. So I think, building capacity at the local level, building stronger School of Public Health, School of Medicine, it will be great. Just great to have Eric Gooseby here, who, before he left PEPFAR, I don't know if you've heard about the HRH program, for example. One of the innovative ways that Minister Binagwaho, worked with Eric Gooseby to implement that. So we looked at all, PEPFAR implementing partners in Rwanda. And the minister asked a very provocative question. I was in that meeting. He said, I want to know how much money the US government, so the American people, because we write from the American people, how much money they are really giving to the Rwandese people. And everyone in the room was very calm, say, we can't tell you how much money because it's so difficult. And she said, how come? I need really to understand how am I going to thank the American people with their generosity. I need to understand how much money are you giving to all the implementing partners? And it was a big battle. They said, no, it's very difficult to get the figures because it's very complicated. I said, no, give me the figures, then we will know how much money we really need in terms of programs, and then the excess money, we will invest that money into building our doctors and specialty program, and we will invest that money back to the American universities and bring them so that we will use the HIV, TB, malaria money to respond to our needs today, because we've been able to scale up many of the programs, but now what we are dealing with is second level problem. It's like to train our specialist doctors, etc. It was very difficult, but with Eric, I don't know how they did it. It happens, and the HRH program today is happening. I think being able to change and to adapt into the system, it's very critical. I'll stop here because I can talk about Rwanda all day long.
Thanks, Paul. That's very informative. So, Dr. Farmer, your thoughts?
Well, it's first of all, there's a simple version and a complex version. And as I just said to someone who's trying to make me be very concise for an interview on a film, I don't do concision, okay? You want somebody else for an elevator speech, not me. But some of the simple points are worth underlining. Obviously, you look at what's happened in Rwanda since the 20 years ago, and you see, especially over the last decade, a little bit more, some of the steepest declines in mortality ever documented anywhere at any time in human history. Now that is something that people in public health had better figure out, so we can, identify, make a list of the reasons that has come to pass, since it is what we all would like to see. And on that list, we have to learn how to differentially weight the factors. And some of these can't be just black boxes, like resources that poured in after the genocide. Well, if you compare what Rwanda received in those initial years to all of the countries surrounding it, Rwanda received less per capita in donor funds than any of the surrounding countries. So it wasn't that. And then you say leadership, and then we start to agree. And I think you described what you described a really difficult discussion. It was much more recent, but again, a reflection of leadership. And I think we have to, learn more about that. I think all of us are interested in learn more. What does that leadership mean? How can it be moved forward? And a third point that's worth underlining, and since you were both part of this, I'm just going to use, again, jargon, is that the vertical enthusiasms that were reflected in the creation of PEPFAR and the Global Fund were very intentionally sculpted by Rwandan leadership from the beginning to strengthen their entire health system, and you could say rebuild it, but also to build it, because there really wasn't ever a strong system there. What there was destroyed by and large in the genocide and war, and I know that because we went there at the invitation of the Rwandan government to a district hospital that was essentially abandoned. There were no doctors, no nurses, RNs, really nothing in the way of supply chain. There was that VC Intégré, the VCT Intégré, the vertical program, but why did we get invited in by the leadership? Because they knew that we would help use those vertical monies to rebuild the primary healthcare system. That was the plan, and it was laid out as a plan. It was also linked to poverty and reduction, gender equity, et cetera, from the beginning. So what they're reaping now, and what I think we could reap around the Ebola discussions, they're reaping the fruit of linking those vertical interventions to really what Julio Frank, who is here with us today, has often called diagonal programs. And that is vertical programs that support these, sorry, Jaime. Jaime, you know what? He always corrects me and says, no, it was Jaime. Okay? So, all right, the Mexican,
and I was just about to step in and
the
do
Mexican mafia of global health equity, 1 and 2, frick and frack, Tweedledee and Tweedledum, they get together, you get good ideas. So that intentionality, as in Mexico, actually, I've known them since 1991, so I'm allowed to say
you're good.
That's part of the mystery of BMW and BWW is leadership is really linked to this plan. And I think this is definitely something we can decipher and share with each other. And again, there are other experiences that are really worth emulating.
Thanks, Paul. I think it's a remarkable thing that a country coming out of the genocide were able to take these divergent resources, Global Fund, PEPFAR money, foundation money, Bill and Melinda Gates, also other bilateral resources, and add them to their own resources so they were truly additive, matched up against a list of unmet needs that were prioritized, and they made their own allocation decisions on them.
And let me just add one thing. If you compare, amen.
It is worth a clap. It really is. It's a remarkable thing.
In terms of those resources, let me just add this. In terms of, first of all, Rwanda was and is a poor country by definitions. It is also, by the way, one of the countries where poverty reduction is proceeding at pace. These are not separate developments. It is that investments in healthcare, education, gender equity, good local governance yield significant growth. But I just want to add that if you compare investments and the fraction of public budgets that goes into public health and compare Rwanda to India, to China, to Guinea, Liberia, and Sierra Leone, the West African countries are very low on that list, and so is India. And China is way higher, and Rwanda is higher than China. So Rwanda is the biggest investor. The Rwandan public sector is the biggest investor in its own public health, as should be the case. And that's, again, not a mystery. That's because the leadership is prioritizing investments in healthcare and education and gender equity, as I mentioned. And that's not a bunch of slogans. Those are there's a real strategy that is reflected in the fact that the best improvements in healthcare are among the rural poor and the lowest income quintile, even though they've been good across the boards.
So one thing I would really like to add here as well is that the way it has been amazing for me to come working from Rwanda directly to Seattle, working for the Bill and Melinda Gates Foundation, where we have, amazing, incredibly smart people, and being able to, sit in big meetings. I'm part of the Global Fund Technical Reference Group, and just listening to the discussion at the global level. I think one thing that we are missing, and that we are really working very hard to make it happen, is really the capacity to involve government and Ministry of Health into discussions. Here it would have been great if there were more Ministry of Health representative coming to talk with, UCSF, Global Health, etc. Minister Binago was supposed to come, but I think there are many Ministers of Health. I think the more we can engage them in a genuine way, I really mean it, genuine way, so that they really, because I think we have very good kind of intentions. People who are here want to change global health. We do care about global health, right? But just imagine a village, a chief of a village, Jaime, we met community health worker in rural villages in Rwanda. Those people, I don't think we care more about their kids and their people more than they do, right? So they do care as well, but how much are they involved in a genuine way into finding solutions, into really being, I think that is something that we are missing, so that we can, engage Ministry of Health, work with them, and even funding directly in a very catalytic way, directly the Ministry of Health, so that they can be able to lift themselves and scale up solutions.
You bring out I want people to start to line up at the microphones, because we'll go to questions here in a minute. So please go up if you have questions. To align the responsibility with the entity that is responsible for the population's health is a wonderful thing. And it puts in proximity the prioritization and allocation maker, decision maker, in direct line with feedback from those who depend and use the services. So you are not trying to talk to Seattle, you're not trying to talk to Geneva or Washington with a problem, something that was funded in this year, did not work out, and you need an adjustment in funding in the second year. But you're talking to the entity that is in country, responsibly in dialogue, looking at the kind of fruit of the labor, and being able to respond to maturation or changing needs of the population. That's a critical relationship that we struggle with as donors in the United States, in foundations, Global Fund. So struggles with that every day. And that disarticulation of that feedback loop, I think, is a fundamental flaw.
There is no one who can put that better than Eric Gooseby, who has been leading this discussion at PEPFAR level. I think what I wanted to really get is that, to the question, is Rwanda replicable? I think yes, it's possible. But I think we need to really be very patient to the people sitting in the Ministry of Health. Because when we are, waiting, expecting a grant application from them, when we're expecting leadership from them, etc., but, our contrafactor is someone who has been well-trained in the US-based or European-based university, who can produce something very quickly, good quality, who can be articulated in talking about things, etc. But that is only for either 6 months, 1 year, right? But the person who will be there for longer, we really need to equip that person and be very patient so that we can build. Because like in my work at the Gates Foundation or at any place, when I go to any country, I try to mimic the people who are making it happen at the Ministry of Health in Rwanda. So you have the guy in charge of maternal child health. You have the guy in charge of community health who has been there for 13 years. No NGO has been able to take that guy because well-paid, well-equipped, well-trained, etc., working for the ministry. I think if we can really try to accompany government to do that, it will be possible to replicate Rwanda. I'm not, Rwanda is not a very good place to talk about the private sector. I think, we need also to understand and to, understand the role of the private sector. In the health sector, it's a very strong public sector, oriented, public health system. But the private sector is booming. But in other countries, like in Nigeria, where the foundation is doing a lot of work, you need equally to understand what the private sector can offer, because 50% of the people are going to get.
Yes, thank you. Emil, are you? We'll go to the questions now.
My name is Anil Soni. I want to tee up something that hasn't been discussed in terms of the Rwandan success story for those in the audience who are not as familiar with it, which is the deliberate use of the community healthcare worker model, not as a response to resource scarcity, but to ensure both better and more decentralized care. And I'm surprised that it hasn't come up yet as one of the key success factors. So for those in the audience who don't understand that system or aren't familiar with it, I thought it would be useful for you all to share with everyone how that works.
Well, if I could just, say one thing about this, because I know a lot of people in the room are interested in chronic disease, regardless of its etiology or purported etiology. And that is that it would be better if we all, I think it would be better or more accurate to say that the highest standard of care for serious chronic illness is by working with community health workers. Like outcomes, whether you look at advanced HIV disease or tuberculosis or epilepsy or diabetes or serious complications of congestive heart failure, et cetera. Whatever it is, if you have a daily deliverable, which each of those pathologies does, and you can link your clinics and hospitals to a really large body of community health workers who are trained and supported, they have to make a living, then you're going to get really much better outcomes than without them. And I just had this experience, and my coworker Joya Mukherjee, who's standing in the door, we've all had this, of going to a conference and having someone say, well, you're only perseverating about community health workers because there are no doctors and nurses, and you would never do that in the United States. And then I'm able to say, that's completely untrue. That's exactly what I wish for the United States, that we had community health workers who were trained and supported to link in with our primary care and hospital system. That would lead to significantly improved outcomes in the United States for chronic disease. Rwanda is ahead in a lot of these matters, including some of the healthcare financing questions, in part because that was the argument that was made. That's in fact why we were invited to Rwanda to roll out a community health worker model with our Rwandan colleagues that was linked to, again, the clinics, health centers as they're called in Rwanda, and hospitals. And the Human Resources for Health project that Pauline mentioned, which was written with the ministry and the Clinton Foundation, CHAI, as Anil knows quite well, was again a deliberate effort to say, okay, if we as Rwanda, the public sector and their partners, because the Rwanda public sector has been very open to partnerships from NGOs in our experience. If we've culled a lot of the low-hanging fruit, vaccine preventable illness, go through the list, what are some of the problems that we see now? Trauma. I mean, this is another reason that Haile and others who've been working on these problems have been so helpful, because if you look at that list, it's major mental illness, trauma, and a series of problems like malignancies that have, again, they require a different kind of intervention, but they still require community health workers. Sorry, but thank you, Anil, for giving
this is
a chance to say that.
If I can add one thing, I think the CHW story in Rwanda, it's a combination of two things. As Paul was saying, really, some of the work that PIH has been doing, like showing that you can link community health worker to health centers and to hospitals, and you can create a way that those community health workers are really connected to the health system. I think also the second part is really the fact that in Rwanda, they tend to look at what the Ministry of Local Government is doing, how the Ministry of Local Government has organized the country, and how the health sector can literally link to that. Because in Rwanda, you have a country which has been decentralized in 2006, and since then, you have 30 districts, and you have sectors, you have cells, and you have a village. And in each village, the government decided that the community needed to select at least 3 community health workers, and there are 15,000 villages in the country, and you have a network of 45,000 community health workers. and then using partners like partner in health, helping the government to create good training material, good supervision material, so that the government can translate that into everywhere. I think that has been really a perfect way to create a national platform. But additionally, as we learned, it's not possible to think that community health worker can be volunteer. It's just impossible. It's not sustainable. You cannot imagine, those, brave women, those brave men who have to feed their families need to work for global health for nothing, etc. It's just not possible. But also at the same time, thanks. But at the same time, there are not many alternatives to pay those community health workers. One of the alternatives is to put them onto the government payroll. But if you think creatively, is that you are going to, even the government is not able to support enough doctors and nurses, etc. You cannot add a new body of work. But now, what the government of Rwanda did in a very creative way is to think about cooperative of community health workers. So they've grouped all community health workers in the catchment area of one health center and created a legal cooperative so that they linked those cooperatives to, they created a performance-based financing system with the cooperative. So they sign an agreement. They say, we're going to pay your cooperative based on key outputs in terms of like service you'll be providing the community. You can take 30% of the money, split among yourself, 70% invest into an income-generating activity, and then, continue to do that. So those community health workers, those cooperatives have been, prospering. Some are doing great, some are not doing great. Just, to call into Dr. Pertozzi's, point about heterogeneity. Huge things to study and understand how those cooperatives are doing, because the more we understand, the more we think about innovative solution to sustain those kind of community health worker programs at the national level, then we can tap into global health financing that are coming into country and tell them to invest into those programs.
Thank you. Last question.
My name is Mary Fontana. I'm a postdoc here at UCSF, and you actually just touched on what I want to ask about, which is about accountability and safeguarding against corruption. And what you mentioned was tying key outcomes to funding, but I'm just wondering if increased scrutiny, perhaps in the wake of the genocide, scrutiny from the international community has helped Rwanda be more transparent and accountable in its use of funding, and whether there are safeguards in place for that, and whether other countries around it, which, as Dr. Farmer mentioned, have had worse outcomes with more funding, whether they might learn from lessons learned in Rwanda about transparency and accountability.
This is a very tough question. So when, I think Rwanda has been really very lucky to have a very strong leadership, which has, zero tolerance to corruption. And it has just gone down up to the community level, because the accountability is there. In neighboring countries, I don't think the issue has been more in terms of like accountability, but I think the strong leadership, strong result-oriented policies are really critical to ensure that money that are coming are really being used for the purpose. Yeah. I think that has been critical.
Well, I thank you, Mary. It's a great question, and I really don't want to sound like I'm grandstanding at all, but I think it's the international community that needs to be held accountable. And it's probably not a likely prospect, right? I mean, after all, the genocide was not an accident, and a lot of the weapons used were not manufactured in Rwanda, and there's a lot of literature on this now that shows that the aid community plays a role in setting the stage for what came to pass. And I think those are important lessons to learn about accountability. When I say it's not a likely prospect, one thing, first of all, we could make it a more likely prospect, right? We could say, here are the rules of the road that we should follow in the international community around aid, how we strengthen local capacity, as Paulina said. How do we link our efforts to generating new knowledge with partners? I mean, I think there's a strong streak of this in some of the aid reform movements in the United States government as well. I mean, everybody in this room is familiar with that streak. And we could go right down the list. How do we make sure that we're not undermining the public sector, which is a great way to undermine long-term confidence in public education, public health, and just good governance in general. So we need to push forward accountability, but I would say that the biggest problems are, where the greatest resources are stockpiled, and that would be in so-called first world countries or developed countries that consider themselves aid donors. That's where we really need to be more accountable. Now, if we fail at that, and I think there's the wherewithal in this room, and that's why I'm here, if we fail at that, at the very least, we better demand aid effectiveness, right? Because that's the least we can do, is say, okay, have we learned enough to measure the outcome of these investments? And we can't just push that all on, ministries of health and community health workers. We got to push that on ourselves.
If I can just wrap this up, and please, our timekeeper here. I think Rwanda is an example of a country that had many unique features that allowed it to position itself to take advantage of the donors' generosity and resources, but to take them into their own process, strengthen their own systems, reflect those resources back in program to give services to their people, and create accountability loops that, as Paulin has said, occur at the village level on up, and a government that expects the leadership at each one of those levels to monitor and police the distribution of those resources. It is something that I think donors in general need to allow to happen, need to be willing to take the risk to step into a partnership with countries that is different than a paternalistic kind of post-colonial top-down relationship that's prescriptive and insensitive to the changing needs of the community, the leadership in the community, the leadership at the provincial and national levels. And I think we're right on the precipice of being willing to take that leap into, as I say, real partnerships instead of the traditional top-down. If we do that, I believe we will energize a process that is more self-correcting and responsive to the needs of the people that we're trying to serve. So I think Rwanda really highlights a lot of those features. I think we're seeing the beginning of that in many countries now, but it needs to be catalyzed by donor leadership to allow it to happen. So I want to thank my friends and colleagues for this wonderful discussion.